Hello, Overcomers, and welcome to this episode of Connect Over Coffee. I'm Runsi, the founder of Overcome, and today we are joined by a great friend and a global expert, Dr. Rod Rocconi. And Dr. Rocconi, we absolutely love your T-shirt. So thank you for wearing and showing the Overcome spirit. So Dr. Rocconi is professor of gynecologic oncology at the University of Alabama and director of research at Infirmary Cancer Care. He is regarded as one of the top renowned experts in this space, and he also serves on several national committees, including the ASCO Gynecologic Cancer Guideline Advisory Group, and has been involved in some groundbreaking work on ovarian cancer. So join us for the next 45 minutes to an hour as we chat with Dr. Rocconi about advances being made in the field of immunotherapy in ovarian cancer, which still remains a challenging topic. And grab your coffee. I have mine. This is fall, and what a lovely time to connect over coffee. And so with that, a huge welcome to you, Dr. Rocconi, to this episode of Connect Over Coffee. Always an honor to have you.
Thanks for having me, and you're too kind with the introduction, and look really forward to spending some time with you this morning.
Thank you. And as I said before, I cannot get over the T-shirt, and chances are I won't until the end of our conversation. So thank you once again. So Dr. Rocconi, let's start with the basics. So unlike many other forms of cancer treatment, we know that immunotherapy doesn't involve any direct interaction with the malignancy. So tell us more about just immunotherapy in general.
Yeah, so I think a good preface of that is at its core, the major challenge in treating any cancer is that cancer uses normal cell machinery to really do bad things. And so in theory, we always kind of have the ability to shut off a potential pathway or potential machinery and shut off those mechanisms in cancer. But the problem still lies in the fact that if you shut that off completely, you also shut off those pathways in normal cells, so normal cells to survive. And so that's the major challenge, I think, in any cancer therapy is, creating something that's very specific and selective to cancer, where it hits 100% of the cancer cells, but 0% of the normal cells. So taking that kind of premise and looking in, immuno-oncology, so using immune, related therapies towards cancer, the normal cells send out signals to the immune system that says, hey, I'm normal, do not attack me. Unfortunately, cancer sends out also those signals, sometimes amplified. So they're screaming with a megaphone saying, hey, I am normal, keep on moving by, don't attack me. And they quote, hide, from the immune system. And in immune cancer or cancer related, we call that immune escape. And so much of our immune therapy to date in regards to how we treat, cancer is really removing that, signal so that the immune cells can recognize a cancer and then attack the cancer. And so we call that a checkpoint inhibition. So immune checkpoint inhibition is a common term that you'll hear. And that's essentially what it's doing is removing that cancer signals to allow the immune system to recognize and then attack the cancer.
Thank you. So what are the different types of immunotherapies that may be offered to the patients today, not just in ovarian, but any kind of cancer?
Yeah, so most of this is involving, as I mentioned, the checkpoint inhibitors that block a cancer's ability to, escape the immune system. But there's also other things that are commonly being used and looked at in clinical trials, such as increases in cytokines that actually kind of help recruit immune, cells to a specific area. And then certain antibodies, and there's multiple ways to, have an antibody created to a specific marker, on a cancer cell. That allows the immune system to kind of piggyback in and help attack. So some refer to that to kind of like a Trojan horse type of phenomenon that takes advantage of, circumventing that signal to say immune escape, being more specific, and then also recruiting immune cells to the area. So those are kind of the general principles when we look at immune therapy today. Oddly enough, immunotherapy has been looked at in theory and principle for 100 years now. So it's taken a little bit of time to get where we are now, but it's an exciting time, I think, for having newer therapies for cancer patients.
Wonderful. So, just like there are, different kinds of immunotherapies, right? I mean, there are also different types of ovarian cancers. So tell us about which types respond better than the others to immunotherapy and why.
So, recently, across multiple tumor types, even outside of ovarian cancer, just cancer in general, we've seen that the higher the mutation rate within a cancer, the more likely it is to respond to immunotherapy. Now, most ovarian cancers are not necessarily mutationally driven, so they have low rates of mutations by comparison, which unfortunately by itself leads to low response rates to that traditional kind of immune checkpoint, immunotherapy. However, these newer targeted therapies that take advantage of the antigens and on a cancer cell have shown some successes in immunotherapy that the checkpoint inhibitors were less effective at. And so with clinical trials and certain things we always talk about in cancer is that even though a percentage of response rate might be only 10%, but if you can really recognize which patients those 10% are, and you get that kind of right drug to the right patient at the right time phenomenon. And I think with immunotherapy, we're getting closer and closer to that as the years go by.
So I have a question about that 10%. So you said, let's say 10 to 15% respond well to immunotherapy. So is there like a pattern to that 10%? Like, is there, what I'm trying to understand is those 10% of patients, do they belong to one type of ovarian cancer versus the others, or is it just spread across and it just depends on the person and her, reactions?
Yeah, I think some of our gaps in knowledge right now is that
Yeah.
we not have a complete handle on what 10% that is.
Right.
Combination of things that are happening either within a specific patient or that patient's specific cancer. And so that, and then also I think combinational assays kind of help. So we're looking at the addition of a single agent immune therapy plus something else, whether it's plus a PARP inhibitor plus standard chemo or even other immune therapy type agents that might help with the specificity, bringing that immune system to that specific cancer cells. Might help us in that regards. But I mentioned some of the gaps. Another gap there is that we just have a single best, predictive marker, biomarker that we can say, oh, if we run this test and get a positive, marker A, then it's going to work. We're not there. It's probably a panel of different areas, and but with the ability now with next gen sequencing to we're able to look inside the cancer's DNA in a very quick turnaround time, of a couple of weeks, even that I think we're getting closer and closer to those types of specific answers to really identify why that percent, has the response that they have.
Yeah, and that is why research is important, right? I mean, that is the reason why we do research, to understand the complexities of this or any other disease for that matter. And it continually evolves, right? So thank you for sharing that. So immunotherapy as just a single agent or as a combination treatment, right? That seems to be the question of the day. What works better? So what is the latest finding in this, and where is science progressing in understanding the different dynamics of care, and what are some of the major conclusions that have been made as immunotherapy as a single agent or in combination?
Yeah, so in regards to response rate and survivals, more is always more. We definitely want to keep improving regardless of what our current standard is. And that's why clinical trials are so important. And so I think that what we're seeing is that with those combinations of immune checkpoint inhibition, if we're adding chemotherapy to it, we do see an increase in response rates. And, PARP inhibitors, we're seeing, some increases there as well, and other immune related therapies. And I think that those are still clinical trials that are ongoing, and we have a lot to still learn about that. But I always use the baseball analogy is that, we might not be hitting a lot of home runs, but if we keep hitting singles and doubles, we can win some ball games. And I think keep moving that needle, and to get further and further and closer to the answer in regards to what patients benefit the most, from a certain therapy.
So the when you were talking about the immunotherapy in combination um, and some of the clinical trials that are ongoing, I was just thinking, you mentioned PARP. So I was thinking that immunotherapy in itself it's not very easy treatment, right? And if you combine that with PARP, that's, to me, just sitting here, it seems like it's a lot of treatment going through your system. So from a toxicity standpoint, through the clinical trials, is there any data that has emerged which shows that it is kind of tolerable and safe for the, I mean, obviously it's safe, but is it tolerable for the patients, or is toxicity a concern that our overcomers need to know or be aware of before signing up on these clinical trials?
Yeah, absolutely. I mean, that goes hand in hand with everything we do. Is that first, do no harm, and we want to make sure that whatever we are doing, whether it's standard of care or clinical trials, that it's first and foremost safe for that patient. And everything has a risk and a benefit to it. But you're right. If we're adding two agents, are we getting double the complication rates? And yeah, that is definitely something that's always, in our minds in regards to clinical trial work. Uh, Oddly enough, sometimes we see that by adding combinations that we get some synergy to where things are not additive. So if you get, 10% here and 10% there from two different agents, and you put them together, it's common sense will say, oh, well, then if it's a 10% response rate with one, 10% to the other, then it's a response rate of 20%.
Right.
Sometimes some synergy, it's even more than that. It can be 40%, 50%, and where the agents kind of play off of each other a little bit, and or sometimes even add some specificity to it. One clinical trial that I worked on, for example, where we used two different types of immune system agents, two types of immunotherapies. One was a traditional kind of a checkpoint inhibitor to reduce the signal. The second was a vaccine-related chemotherapy. Is very, specific, to a cancer cell. And what we saw with that is that we had increased, specificity to the cancer, which is the effect we want. But we saw actually a decrease in the side effects because we were not getting off-target effects to where, a global kind of immune checkpoint inhibitor kind of revs up the immune system a little bit. And we saw actually less immune-related adverse events. Now, that was an early phase trial, but it's one example of that with combinational therapy. Yes, you do have to worry about additive side effects. But there are some specific instances where it might be more specific and actually synergistic and help not only with the efficacy, but also reduce some of the side effects that are there.
So I didn't know when we connect over coffee, we also connect over minds, because you said vaccine, and that's exactly what I was thinking in my head when you were talking about this. I don't have this question here, but I'm just curious to understand I've heard here and there about the vaccine therapy for immunotherapy for ovarian cancer patients. Where are we with that, and what do you see in terms of vaccine therapy in the next 5 years?
So, I guess vaccine therapy or vaccines are kind of a broad topic in and of itself. But
Right.
in regards to, the way I think of a vaccine therapy for cancer, is that you're really looking at a very specific marker on a cancer cell. One example is of something that's been in clinical trials here recently, been published about, is mirvetuximab for ovarian cancer, looking at folate receptor alpha, very specific marker. And the higher that expression is of that marker, the better this agent works. And it really kind of, the antibody itself, that vaccine, is drawn to the folate receptor alpha, And like a Trojan horse, it brings some of that immune, effects with it. And so we get a very, specific target into that, cancer cell. And this goes hand in hand, I think, with, we talked about right patient, right drug, right time. Uh, and something I talk with my ovarian cancer patients with, frequently is that, if we line up 100 patients with ovarian cancer, they all have the same, cancer disease. But if you look at the cell by cell or their cancer cells, there might be 100 different, pathways or 100 different specific markers that they have on their tumors. That really, it's different in how their tumor grows, metastasize, and in different ways that we need to inhibit that and kill those cells. So the more we know, I think the more we realize we don't know. And that's why it's so important, so that we really try to figure out at its core basis, what is the root problem, patient by patient, because that's the most important thing is the patient sitting in front of us at that time.
So what I understand, like for this vaccine therapy, it's not like the COVID vaccines that everyone can take it, every ovarian cancer patient. It is more personalized. It's more specific to the disease state of the patient and what you think from an expert point of view that this person will benefit more from this therapy versus the other. So there's a little bit of discrimination that goes on here. Probably discrimination is not the right word, but selection that goes on in terms of this particular form of therapy. Is that the right understanding?
Absolutely.
Okay. All right. Thank you. So, so we are hearing a lot about this drug factory implant. So we are actually, we have made some contacts with Dr. Vesa at Rice University because we are in Houston, and he's doing some phenomenal, exciting work, and clinical trials are about to open on these drug factory implants. So this sounds very exciting when it comes to immunotherapy for ovarian cancer patients, because I have visited his lab as well and have talked to him a few times. And it seems like in mice, at least, the response rate is spectacular, to the point where they have seen complete elimination of ovarian cancer. So we have reasons to hope, even though we know that when it transfers into a human clinical trial, it's not the same. But from your standpoint as an expert in this space for several years and decades, tell us more about what you think about the merits of the study and how you see this unfolding for ovarian cancer patients.
Yeah, no, it is without question very exciting and evolving field, and the methodology of this delivery system is unique, and something I akin to we've been doing for a while anyway with this kind of drug factory implants is, usually it's with hormonal therapy with people with imbalances in their hormones. There's pellet therapy where people would inject it to the skin to kind of help, with certain hormones, and this is just with this kind of implants per se, it's really trying to overcome some of the obstacles of treatment in specificity, right? And so you can package, the immunotherapy or the cytokines, within this little implant, and put it either directly into the tumor or, per at least what I remember from the study, the published report, it was adjacent to or next to the tumor implants in the mice itself.
Right.
And so really, by doing that, you're bringing, the cytokines in the immune system right to the area of need, at the cancer. And I think it's very exciting to look at and to think about, that prospect of having an implant to help treat, a cancer. Now, granted, as you mentioned, we have to look at this in clinical trials, have to look at the side effects of doing this. I mean, it is more invasive, but can be easily done, and help determine, the safety, the feasibility, and how effective it is compared to other methods as well. So, in my opinion, it's exciting and definitely something to keep an eye on, and but moving the needle towards getting more specific treatments, to the area of need.
Yeah, I mean, I think, this is as you said, the drug factory implants, this particular idea is not very new. It has been here for a while, but I just feel that, just trying to do this for ovarian cancer patients is a novel space, and we are just excited about this, and hopefully it will translate into something, positive for these patients. I just heard that they are opening. It's already the clinical trials. It's already up on the website, and so they're enrolling starting this month or something like that. So
One other thing I think I really like about the thought process and the idea here is that, ovarian cancer, for the most part, is a disease that's confined to the abdominal cavity.
right.
So having a localized, quote, localized cancer, treated with a localized therapy with implants in the abdomen, in that what we call peritoneal cavity, it makes a lot of sense. And it's part of the thought behind intraperitoneal chemotherapy and why that got started and continue to be evaluated. So in my mind, this is a natural progression of the art of clinical trials and science to hopefully get better results.
Right, and it seems to be a perfect union between engineering and medicine, right? So which is also exciting because they are coming at it from a very different perspective, from a bioengineering perspective versus medicine. So I hope, I'm very hopeful that this will work out in the right direction, because so many patients could benefit from it if it does. So fingers crossed on that. So speaking of that, this brings me to the next question. Tell us about some of the recent trials that you're running at your lab and the goals you hope to accomplish from these trials, and what is your vision, and what are you most excited about when it comes to immunotherapy for ovarian cancer?
Yeah, one of I guess my main focus right now is on Vigil, which is immunotherapy that I've partnered with Gradalis, a company that created this Vigil immunotherapy. And we've had some, really good results in ovarian cancer in, phase 1 and 2 trials, and hopefully, starting the phase 3 trial, sometime soon. But just to kind of talk a little bit about the vaccine, because I do think this Vigil immunotherapy, because it does incorporate a lot of the themes we've already talked about this morning, over coffee, but in broad scope, I kind of consider it a three-legged stool. And if you don't have all three of the legs, then the stool falls and you're not successful. And so the first leg of that stool is that this is very specific to a patient's own tumor cells. So we actually create this from after we do surgery for a patient with ovarian cancer. We take a portion of the cancer, and we look at those receptors, those antigens, on a patient's cancer cells, which I kind of alluded to earlier. It's so different, patient by patient, and then we create, a targeted, antibody towards those specific antigens. So a vaccine or an immunotherapy created, a Vigil created for Mrs. Jones is only good for Mrs. Jones's cancer.
Right.
Johnson over here needs a separate, vaccine or immunotherapy created. So that's the first leg. It's very specific to the antigen. Second is that there's a booster in the immune system. So it's genetically modified, this treatment, to bring the immune system to that area. So that's antibody attacks that, those receptors. It brings some immune cells to the area to get a more robust immune response. And then the third thing, there's a natural enzyme, TGF beta, that usually the cancer uses TGF beta to shut off the immune system. So if the immune system is attacking the cancer, that's its defense mechanism. And so the third leg of this stool is actually, shutting off TGF beta so the cancer can't push away that immune system.
Right.
So I think it's pretty unique because it's very specific. It boosts the immune system, sort of like a car analogy, where you're putting the pedal to the metal so you get it going as fast as you can. And then the brakes, which is the TGF beta, we're cutting the brakes line. So now, this response can go as fast as it can without any brakes to slow that down. And the early results have been very promising. Now, some of the things we're moving forward looking at, again, is trying to figure out which patients respond the best to this therapy.
Right.
Also, and looking at different biomarkers that we can be very predictive and say this is the right type of patient, for this treatment. But to date, it's been very exciting, and we're looking at that, and also the thought of potential combinational therapies, with this. With other therapies. And I kind of failed to mention, one of the best things about this is the side effect profile. The
Yes.
toxicity profile is very low. The fact there were no serious, adverse side effects. It was only grade 1 or grade 2, which are both mild. Site irritation, comparing this with the placebo. And so, and the placebo and the medicine actually are quite equal. So, so patients were able to get this therapy without much side effects, which is always a huge plus.
So how many patients do you have currently enrolled in this?
Yeah, so the study we just completed had 92 patients, and it was a
92. Okay.
nice control trial, but a phase 2. So, in about half of those patients, 47 actually received the vaccine compared to placebo. And the way we're using this is patients who have frontline new diagnosis of ovarian cancer. They get the standard surgery and chemo that everybody gets, but then at the end of their chemotherapy, they are randomized, patients are randomized to get in the placebo versus the vaccine. And so that's how the phase 2 trial was run.
So I'm curious. So after the vaccine therapy for the selected patients that out of this trial, then what is the next? Are they being followed for X number of years, or how is that
Yes.
progressing?
Yeah, and we're still following those patients. The most recent publication we had on that patient data set was looking at survival rate or 3-year overall survival endpoints. And so, and the difference, in the patients with the vaccine, or the Vigil compared to placebo, was over 70% with the Vigil and 40% with the placebo. So a significant, increase, not quite double, but
That is significant. I mean, we will take 1%, 5% over what you are talking 30% over. That's a lot.
that's a nice sizable jump. I mean, we're all
Yes,
cautious because we don't want to overpromise anytime
of
in clinical.
course. Yeah.
But the data is the data, and that's what we saw, and I think it gives us enough information to move forward in further studies in a larger trial to make sure that type of efficacy holds up. And so
Wonderful. Wonderful. That's very hopeful news. Thank you for sharing that. And so they are not on any other kind of treatment at this point in time.
uh, no further treatment at this point in time. So that's a good point, because with that Vigil, it's given once a month for up to 12 months.
Okay.
So right now, all the patients have received their entire, Vigil. And the thought is that it kind of primes the immune system to recognize. So, for example, if cancer cells were to recur or develop, that if it still has the same makeup, the same antigens, the immune system should recognize that. And so it kind of primes that immune system to recognize it and attack it again.
So they are staying on this once a month, and that is the only form of treatment while they're being followed.
Well, once
That
a month.
sounds fairly easy.
Yes, it is fairly easy. And so just a shot in the arm, once a month for the first 12 months after they finish chemo. And so all the patients that have completed that are now just on follow-up.
That's wonderful. I mean, fingers crossed that this also reads out very well so that, more patients can benefit from this. Wonderful. So it just seems like immunotherapy isn't that, doom after all. I mean, there's a lot of stuff that's ongoing that is promising. So we are finally getting to a point where immunotherapy could break the barriers in ovarian cancer.
Yeah, I think so. We're seeing multiple examples of that.
Yeah.
I mean, I think with the Vigil, trial, the Vital trial using Vigil, I think is one example. The drug factory implants is
Right.
another things moving forward. Mirvetuximab that I mentioned earlier, looking at folate alpha is another, of many examples of us getting more and more specific So we get that precise, cancer effect, while also trying to limit the side effects best we can. So convenience is also a big thing too, right? I mean, if this is as simple as taking a pill or getting an injection, or then I think it's a little easier than sitting.
Absolutely. Absolutely. One curious question, Dr. Rocconi, for folks that have autoimmune conditions of any nature, right? I mean, anything. How do they respond to immunotherapy?
Yeah, unfortunately, at this point in time, patients who have, immune-related diseases are not candidates for
Yeah.
immune. And so, if we're looking at, I guess, certain situations where patients are not eligible, that is one area.
Criteria. Mhm.
And then other things, depending on the certain side effects, of certain immune therapies might affect the liver more so than other, or the kidneys, or other infectious diseases that patients might have. Those are all part of the exclusion criteria of some of the studies that are there.
And this is for all autoimmune, not specific. Any autoimmune disease just kind of excludes you from participating.
So right now, because the concern is how, considering most of these therapies are kind of revving up or turning on the immune
Yes,
system. And so if someone already has a disease where their immune system is causing harm, we
right.
don't rev that up any for those patients. So
That makes sense. Yes.
down
Thank
the
you.
more and more specific, we might be able to tease that out a little bit, but right now,
Yeah,
unfortunately.
that makes sense. Safety first, right? That's what we need to do. So in which, and speaking of that, in which situations, we talked about the autoimmune conditions, but which other situations is immunotherapy not an option? And we talked about the toxicities a little bit. And how do you actually determine the best candidates for immunotherapy and for who you decide to discontinue? Let's say that person is on it, but you decide to discontinue. Tell us a little more about that.
Yeah, so if a patient is on immunotherapy, whether it's standard treatment or part of a clinical trial, a lot of the side effects we see from that are immune related, and so patients can present with symptoms that look like a pneumonia,
Yeah.
or a colon infection, a colitis, and now granted, patients can have a bacterial pneumonia while on therapy, but if they have pneumonia symptoms and on immune therapy, that could be related. And depending on the severity of that, how easily it was treated, and depending on the protocol, depends on if the patient can stay on the therapy once they recover, or do we have to discontinue. And it's, I think, in situations where it makes sense if a patient is having not having a response to therapy and then start having side effects, that's an easy decision, saying, hey, one, this isn't working well. Two, we're having some side effects to it. We have to move on. The times where it really becomes difficult is when you are having a response, but the toxicity
Yeah.
is so high that it's really affecting not only the effectiveness of the agent, but also
The quality of life is compromised. Yeah. Mhm.
compromise. So that's a patient to patient kind of discussion, depending on where they are in that journey, and it's truly kind of where I think that the art of medicine and the physician patient relationship really comes into play. And again, first, do no harm, and always we're looking at the quality of life, and we're greedy. We want both. We want the quantity and the quality
Absolutely.
at the same time.
And to your point, I mean, it is, ultimately it's the decision of the patient, what he or she wants out of the treatment, because we have talked to patients who have given up on treatments, who have, just said no to any more treatment because that's how they choose to walk their path. But there are other patients who will try every and any alternative that's there to kind of, help them through the journey. So it just depends where the patient is too. I mean, to your point, where it's a dialogue between the patient and the physician on the options that are available and what is the balance that they are seeking in the end.
And it's something, and I think I'm not unique in this. I mean, it's something I think we all do, is that our we really just we want to respect our patient's wishes
Exactly.
and give the patient here's our choices. We've got A, B, and C. Here's what we can expect with A, B, and C. And again, we're there to help respect the patient's decisions, and they make their decision, and we facilitate and do everything we can to ensure that we're following the path that they want for themselves. And including an example you brought up, where there's some patients say, "Doc, I hear you, but I don't want anything else." That's fine too. And it's part of our job, really, to have those discussions with
And thank you for saying that. It means a lot, because not all physicians in all communities do the same. We have been in many situations where the physician decides for himself or herself what is best for the patient. And this story, it's not new, but just spending that time understanding what the patient's perspective is so important. And thank you for honoring that. I wanted to keep this on record, that we appreciate you for doing that with your patient community. So we have talked about this in detail, but we understand that immunotherapy is a complex field when it comes to ovarian cancer, right? And so we know that we are in the early stages, but what hope in the horizon do you see for ovarian cancer in the next 5 to 10 years, and that you would like to share with our overcomers?
Yeah, one of the most exciting things to me, I think, is the pace of discussions. You mentioned 5 to 10 years. That seems like a lifetime from a research cancer life cycle now. I think what used to take us 10 years to evaluate, we're doing in 2 years. And so I think the emerging trends in immunotherapy, or just cancer therapy in general, that are very encouraging to me, is that we're becoming more and more specific, more and more individualized, to where we're not just treating, quote, ovarian cancer cookie cutter, everybody gets this regimen. We're treating Mrs. Jones's cancer, that has this specific marker with this specific change in the DNA of her cancer, and by doing that, getting more precise with the effect we have on cancer cells, which, if we're more precise on that, we're decreasing the side effects, and it's becoming less toxic. And so those go hand in hand. And I think it's very exciting to be in this kind of precision oncology world that we're in now. And I mentioned a little bit earlier too about the convenience of it. I think if we have agents that are oral, to where a patient just takes a pill every day, instead of having to drive to a cancer center that might be around the corner, or in my neck of the woods in Alabama. I mean, there's patients that travel 100 to 200 miles to get to a cancer center that has clinical trials and things
That
like
is truly life-changing, Dr. Rocconi. I mean, that is truly life-changing, making it convenient for the patients, just a shot or oral pill or whatever that may be. Especially to your point, some patients are traveling 200, 300 miles to come to the center. And we work with so many community patients nationwide that tell us that it's not always, it's expensive, right? I mean, not only the cancer treatment is expensive, but everything else related to it, the parking, the drive, the time and the resources, all of that is, it's serious. So, I mean, anything we can eliminate from this whole list is just absolutely fabulous.
Well, and I think that along those lines, I mean, it is, we talk about toxicity from treatment, but the emotional toxicity and anguish of, here we go again. I hate driving into the city. I hate going to this. The financial toxicity of it is costly. Everything you do, from gas and gas prices being high, to wear and tear on your vehicle. I mean, all those, time off of work, and I think we need to do a better job, and I think we are, and at least we're recognizing, being cognizant of the fact that we need to do a better job of getting the care to the patients, as opposed to saying, "Hey, we're the ivory tower. We got to have the patients come to us."
Yeah.
And these more convenient methods of treating patients make that a reality, and so that's exciting as well. When we talk about the horizon, next 5 to 10 years, I see all of that moving together, with more precise therapies, less toxicity, ease for the patient, and quality of life, not only from a cancer standpoint, but just overall treatment. And for many patients, living with the cancer, we want to eradicate it, but for those that we can't, we want to make sure that quality is there at the highest level.
Absolutely. That's a brilliant answer, Dr. Rocconi, because we know that, a cure is the end game, right? We are all, striving towards it, but that may take a little bit longer than, making cancer a chronic condition where you live with it for as long as you live with it, and then you can enjoy a full life. You can have, like you said, we can try to reduce the financial, the emotional, the social, all of those toxicities involved, and make it easier and friendlier, for the lack of a better word, the treatment a little more friendlier for the patient. So that is truly life changing. So that is a lot of hope in one sentence. I just wanted to mention that to you.
Yeah.
Thank you, Dr. Rocconi. So I've asked you a lot of questions. What have I not asked you that you would like to share?
Well, you know what? First and foremost, I greatly appreciate the work that you are doing and the whole Overcome, society. It's so important to have allies and friends, and recognizing that each cancer patient's journey is their own. And so I guess if there's one thing that I would say, I guess, to the Overcome community, which is a little bit preaching to the choir because the guys are always doing that, but I encourage all my patients to get involved at the level at which they want their involvement to be, and whether that's just joining a cancer support group, whether that's starting a cancer support group, there's one not in their area, helping raise money for research, advocating, to whatever level they want to. And we've got some really, really powerful patients who are doing yeoman's work, and I definitely appreciate that, and the work that you guys are doing.
Thank you, Dr. Rocconi. So before we sign off, in one sentence, I mean, I'm just being hard. You don't have to do one sentence, but what is your message?
It's hard for me to do a one sentence answer to anything.
What is your message to our overcomers listening to you today, and not just in the US, but worldwide?
Well, I appreciate the opportunity to share some coffee this morning. So, but we certainly could not do this in the ovarian cancer treatment world without advocates such as you guys. And it is exciting to see how fast the science is moving. But we are all on the same team trying to eradicate ovarian cancer, and so all our patients can live longer, healthier lives. So more cures to come.
Thank you so much, Dr. Rocconi. This was a brilliant conversation. You have shared so much with us. Thank you, and grateful to you for your time. And overcomers, hope this was beneficial for you. I know I learned a lot from Dr. Rocconi today, and it seemed like our minds also connected as we connected over coffee. I'm saying this again. So please share this video far and wide with anyone who may benefit from all these wonderful insights Dr. Rocconi shared with us. And we will be back with the next episode of Connect Over Coffee very soon. Until then, you keep overcoming. Thank you, and bye.